cementum is derived from the Latin word which means rough quarry stone. The most important thing about cementum is that it is avascular. It is a bone-like mineralized tissue. It has very close resemblance to the bone, and it covers the dentin of the root. The fibers of the periodontal ligament attaches to the cementum on one end and on the other end to alveolar bone. And there are other synonyms which you don't have to really know from exam point of view, but as a dentist, I think it's good to know, because in the Western countries, they like to remember the other terminologies. So substantia ossea dentis, because ossea is your bone, and substantia is substance. So the one which resembles the bone, the tooth structure which resembles the bone, is cementum. Okay, it's also called as tooth cement, because it is on the periphery, and like I said, it resembles rough quarry stone like cement, so it's called as tooth cement. So physically it is pale yellow in color, but when it comes to the consistency or the hardness, it is softer than the dentin. We're comparing it with the adjacent structures, okay, for you to remember. The permeability, I think I explained to you the word permeability. It allows certain things to be passed, okay? So the permeability of cementum varies with the age, okay? That is, it will be higher when you're younger, but it decreases with the age. And also the type of cementum. There are two main types, cellular and acellular. So cellular is more permeable compared to the acellular type. So it's depositing at a faster rate, so the cells which are forming the cementum itself become entrapped. Same thing with bone and other structure. When the osteocytes are getting entrapped, that's in the bone. So cellular cementum is more permeable, and it is more permeable than dentin. When you compare it with the dentin, it is more permeable. So this is your tooth. Okay, and there is gingiva here. Okay, so that's the normal level of your gingiva. Okay, and suppose the gingiva recedes. Suppose the level of the gingiva goes down like this. So this entire area of the crown as well as the root are exposed to the oral environment. Okay, so because of that, there is removal or destruction of the cementum. It is not so strong that it can withstand. So the plaque, calculus, or even masticatory load, many things can just remove the cementum from the surface of the dentin. So what happens then? So the dentinal tubules are exposed. So there is sensitivity in the tooth. Okay. Chemical properties by weight, it is quite close, that is 65% in organic. Organic is 23% and water is 12%, and by volume it is 45%, and organic is 33 and water is 20. So the hydroxyapatite crystals are similar to those which are present in the bone. You know that hydroxyapatite forms the structure of all the hard tissue from your enamel, dentin, and cementum, bone, everything. Okay, there is more concentration of fluoride at the surface, which is considered as a trace element, and the molecules which are involved in mineralization are bone sialoprotein and osteopontin. Okay, so this is the molecular aspect. Okay. So let's go to the classification of the cementum. So depending upon the time of formation, primary and secondary, okay, whatever cementum is formed during the root formation is called as primary cementum, okay. But once the tooth comes into the functional position, whatever is formed, and it is formed like during later on in life, throughout the life as well, whatever is formed, like in the apices, I'll tell you a type of cementum which is formed. It's called as hypersomatosis. That is called as secondary cement. Primary during the root formation. Secondary is after the tooth comes into occlusion. The second is coronal and radicular. What do you understand by that? This is the enamel, dentin, okay? Radicular dentin, pulp. This is the coronal dentin. The brown structure which you're seeing is the cementum, okay? So whatever is covering the crown here, okay? So that's the coronal cementum, and the cementum which covers the root is radicular. This we've finished, acellular and cellular, we discussed also. Presence of cementocytes and absence. Presence of collagen fibers, okay? Based on that, it is classified as fibrillar cementum and afibrillar cementum. Fibrillar, of course, there is presence of fibers, and afibrillar, there is absence of fibers within the cementum. And based upon from where the matrix fibers are originating from, it is classified as extrinsic and intrinsic mainly. Extrinsic fiber cementum, the fibers are derived from the periodontal ligament. In intrinsic fiber cementum, the fibers are derived from the cementoblast themselves, okay? And in a mixed fiber cementum, both PDL and cementoblast contribute for the formation of the fibers. So Schroeder's classification is nothing but a combination of whatever we discussed before and this, the origin of the matrix. So he classified them as acellular, afibrillar, based upon the presence of the cells and the fibers. Acellular extrinsic fiber cementum, that is based upon the combination of presence or absence of cell and the origin of the matrix fiber. Cellular intrinsic, again the same combination, presence or absence of cell and where it is derived from. Cellular mixed stratified cementum and intermediate cementum. Okay, so maybe I will the kind of question I will ask is the type of cementum in which the origin of the matrix fibers is from cementoblast is called as, and then maybe I'll give a list, or maybe I will say the type of cementum which does not have any cells and the fibers are derived from PDL, then you should say it is acellular extrinsic fiber. So acellular and cellular, this we already know. Acellular is when the cementocytes are not entrapped within the forming cementum, whereas cellular cementum is when the cementocytes are entrapped within the matrix. So this is the histology. So this is the radicular dentin or the root dentin. This is the periodontal ligament fibers. And this layer here is your cementum, okay, this thin layer. And if you notice, there are no cells present, and that is why it is called as acellular cementum, okay. And this is the cellular cementum because you can clearly see the cementocytes which are entrapped within the cementum, okay. And this is your periodontal ligament fibers, and that's the dentin. So these are some of the differences between acellular and cellular. This we already finished. These are the cementocytes. So there is a very important structure which you should know called as Sharpey's fibers. Okay, Sharpey's fibers are nothing but the periodontal ligament fibers which are entrapped within the cementum. Okay, so these are your external fibers basically. Okay. So this, you know how periodontal ligament is attached to the cementum, correct? So suppose this is the cementum. I'm just going to draw it very thick. Okay, and I will just pick another color just for you to understand. And suppose these are your periodontal ligament fibers, okay? It is attaching the cementum to the bone, yeah? So this is the bone. Bone, I'm just drawing these holes to understand that it is bone, okay? The spongy bone in the center. Okay. So this is the cementum, this is the bone, and this is the periodontal ligament. So the part of the periodontal ligament which is entrapped within the cementum is called as Sharp's fiber. So this is just to show that the cementum is also undergoing an incremental pattern of deposition and mineralization. So all these lines are nothing but your lines of salters, which is indicating the successive layer of deposition and mineralization. This is the dentin, cellular intrinsic fiber cementum. Just a different stain used for the same slide. So you will see periodontal ligament fibers here. This is the bone, the Haversian canal, and there are osteocytes which are entrapped within the bone, and this is the dentin. And same here, that's the cellular intrinsic fiber cementum, and this is acellular extrinsic fiber cementum, but the same manner, you will see the incremental lines and the periodontal ligament fiber, which is getting attached to the cementum, and there is dentin. Okay. So the interface between the periodontal ligament and the cementum is shown here. So these are the extrinsic fibers, and this is your intrinsic fiber. So intrinsic fiber is formed by the cementoblast itself, whereas the extrinsic fiber is derived from the periodontal ligament, which is an external source. Let's discuss each type, which not each type, but a few types we're going to discuss. So acellular, afibrillar, you already know there are no cells and there are no fibers. This lacks collagen. Okay, collagen makes up a very important component of all your hard tissue, especially dentin cementum. Okay, and that's the reason why this type of cementum does not play any role in the tooth attachment, because it doesn't have how can I say, it cannot withload the stresses, the occlusal stresses or the masticatory load. It is deposited over the enamel and dentin in proximity to the cemento-enamel junction, and that's the reason why it doesn't have much role in the tooth attachment, that is its location as well. Okay. And the cells which are responsible for production of this type of cementum has not yet been identified. What they say is like it's deposited at the end after the cementum formation. So the distribution of cementum along the root, how is it distributed? This we already studied in the differences also. But like I said, the acellular afibrillar is at the cemento-enamel junction or in the cervical area. Acellular extrinsic fiber cementum is the main type of cementum which you will see on the root, especially covering 2/3 of the root. Okay. In case of incisors and canines, that is a single rooted teeth, it might be seen all throughout the root and increasing in thickness towards the apical portion. And the thickness is about 50 to 200 micrometer in thickness. Whereas the cellular intrinsic fiber cementum is more seen in the apical 1/3 and in the interradicular region, like I said, that is between the two roots of the posterior teeth, especially your premolars and molars. And it is usually absent in the single rooted teeth, and its presence is not really essential for support. So acellular extrinsic fiber is the main type of cementum which is responsible for the support or the anchorage of the teeth. So we understood how the cementum is attached to the bone through the periodontal ligament. Let's see how is the cementum attached to the dentin and how is the cementum attached to the enamel now. So cementum and dentin, the attachment mechanism is similar for both the types of the dentin, that is cellular and acellular. And the mineralization of the dentin will start internally as soon as the dentin matrix is formed. And it does not reach the surface until the collagen fibrils of dentin and cementum have had the time to mingle together. So the meaning of this is that once, first the dentin is formed by the odontoblasts, Then there is a break of the Hertwig's epithelial root sheath, and the ectomesenchyme comes in contact with the dentin, and that's when it becomes cementoblast and forms cementum on top of the dentin. So the mineralization will already have begun within the dentin as soon as it's formed. It is not going to wait until it comes in contact with the cementum, but then the mineralization spreads. Okay, so the how can I say, the nidus of mineralization or the foci of mineralization is the dentin. So the mineralization begins in the dentin, and once the dentin and cementum comes in contact and the cementodentinal junction is formed, the mineralization spreads. So that was between cementum and dentin. Now we'll see what is the junction between the cementum and the enamel. So to make it easy for you to remember OMG, like oh my God. Okay, so that's the rule for you to remember. O is for overlapping, M is for meet, and G is for gap. Okay, overlap, meet, gap. So that's OMG. All right. So the overlapping junction where the cementum overlaps the enamel. Let me show you the image. So this is the cementum and this is the enamel. Yeah, because this is the crown. All right. This is dentin here. So dentin is radicular dentin and coronal dentin. And this, of course, is enamel. So when the cementum overlaps a part of the enamel, that's called as overlapping type, and that's the most common type, and it is present in 60 to 65% of the teeth. Next is M, or meets. So the cementum just meets the enamel here. Okay, so as you can see, there is no overlapping, it is just meeting at the junction. Another picture, again overlap. Okay, this is very nice image. Yellow is your enamel and the blue is cementum. And this is the gap, where there is a gap between the two. And the third one is the meat. Let's talk about functions of the cementum. The first and foremost, we already know it attaches the tooth to the bone, isn't it? So it helps in attachment of the periodontal ligament fibers to the cementum, and hence it helps in attachment of the tooth to the bone. And it serves as a protective layer over the dentin. I think I explained to you what happens whenever there is gingival recession, correct? So cementum and gingiva, they both are actually covering, it's a part of the periodontium, right? So it's actually covering the dentin, and hence we won't have any sensitivity. And it is also protecting it against the masticatory forces as well. What happens is whenever there is an occlusal wear, meaning the occlusal surface kind of becomes flattened because of grinding or bruxism or just aging, okay? So when that happens, I've told you that, it's a beautiful love story between the two teeth. They always want to be in connection with each other. So the tooth wants to be in contact with the opposing tooth, okay? So there is a deposition of the cementum at the apices here in this area, so that this surface moves upwards and is in connection or in contact with the upper teeth, okay? And what about the proximal wear? So even on the proximal surfaces, there could be some amount of wear in these areas. That is in case of orthodontic tooth movement, which we will see now. So that is compensated again by the deposition of cementum, okay? And whenever there is a fracture of the root, cementum is supposed to, in some amount, not to an entire extent, but it helps in some amount to repair in fracture of the root. That's why the word contribute, okay? So it contributes to some amount for the repair of the root. I told you that cementum is very close to the structure of the bone when it comes to the structure. But the difference is that it is not avascularized. I told you in the definition, it is an avascular tissue, okay? That is the reason why it is resistant to resorption compared to the bone. It has very minor ability to remodel. Like I said, that's how it helps in the repair if there is any kind of fracture. 70% of the bone is made by the inorganic salt or the mineralized component, whereas in cementum it is 45 to 50%. So there are two unique cementum molecules which are called as cementum attachment protein, or shortly called as CAP, and insulin-like growth factor, which are lacking in the bone. So these are some of the differences between the bone and cementum. So I told you excessive deposition of cementum at the apices, yeah, to compensate for the occlusal wear. It is called as hypersematosis. So this hypersematosis can either be diffuse or localized. Localized means it is in one tooth, whereas diffuse means it's in all teeth, okay? So you just apply it like that. In case of functional teeth, whenever there is hypersematosis, it is because of the hypertrophy, okay? When the size of the cell increases, and that's why the tissue is becoming bigger. I mean, the cell is becoming bigger, or tissue or whatever it's deposited is becoming bigger. That's called as hypertrophy. But if it is an increase in the number of the cell, it's called as hyperplasia. So that's what we see in a non-functional teeth. And like I said, as a compensation for the supra-eruption of the teeth. So sometimes what happens when there is an opposing tooth which goes missing because of extraction, or the caries has eaten the tooth completely, so it is missing in the opposing arch. So this tooth starts supra-erupting, trying to find the opposing tooth, and in that case, there is hypersematosis and tooth wear because of bruxism, attrition, because of aging, grinding of the teeth. So all these causes results in tooth wear, and again there is hypersematosis at the apices. So the entire orthodontic treatment base is based on the principle of pressure and tension. Okay, so whichever side you want to move the tooth. So here the clinician is trying to move the tooth to this side. Okay, that's why there is compressed periodontal ligament, as you can see, and here you will see the periodontal ligament is widened, correct? So the tooth from here is trying to be moved to this direction. So wherever there is a pressure or wherever there is an area of tension, there is going to be bone resorption, and wherever there is this area of relaxation, there is bone formation. So that's what you see here, bone formation in the area where the tooth is being moved away from, and the direction where it is moving towards, there will be bone resorption so that it can be accommodated in that space, and you align the teeth in exactly the manner in which you like it, okay? And all this is happening because the cementum is resistant to resorption. So it transfers all the pressure to the adjacent bone through the periodontal ligament. So all three are acting together. Cementum, periodontal ligament, and of course the bone are acting together during the orthodontic tooth movement. Cementum contributes whenever there is root fracture, but not to full extent. So that's why there is no remodeling to the complete original dimension of the root. Just to show you very quickly. Okay. So this is the tooth. Say this is the apices where there is fracture. Okay. And this is the apex. So the cementum is just deposited around it like that. Okay. So it's not like it will become proper again like that. It will just heal or repair, but not to the original dimension. So let's move on. So there's some structure called as cementicles, which is very similar to your denticle. Similarly, we have cementicles, which is seen either freely or as attached pieces in the periodontal ligament. So this is the attached cementicle, which is attached to the cementum, and free cementicle is lying freely within the periodontal ligament. So this is cementum and this is periodontal ligament. This again is because of the micro trauma. Whenever there is small fracture or there is some very small trauma, then some part of cementum is chipped off and then later it is rounded off. Okay, and this is especially common in the apical and middle 1/3 of the root.
Thank you. Keep smiling.